I'm Francisco Hidalgo from the Department of Cardiology of the Reina Sofia Hospital from Cordoba, Spain. It's a great pleasure for me to be with the Radcliffe interview. So it's a big pleasure for me. Yes, well, as you know, the use of a physiological assessment is a routine practice in the contemporary cath labs. The IFR presents the advantage of a quicker evaluation and the absence of side effects derived from adenosine administration. However, their evidence supporting their use in acute coronary syndrome is scarce and derived from a sub-analysis of the main trials with only 222 patients and 12 months follow-up. But the association between acute coronary syndrome and the presence of other non-corporate lesions is very frequent in daily practice and required of PCI decision making of label, but our group has been using the IFR to determine the need for revascularization of non-corporate lesions. For this reason, we decided to study the usefulness, safety, and efficacy of a physiological evaluation with IFR of non-corporate lesion in patients with acute coronary syndrome with successful revascularization of the culprit vessel. Yeah, we perform a multi-center registry where we include 356 patients with acute coronary syndrome, STEMI and no STEMI, in whom the IFR was used to guide the need for revascularization of non-corporate lesion between January 2017 and December 2019 in four high-volume PCI centers of Spain. The total of non-corporate lesions included were 472 lesions. The cutoff value was the established in the main trial, 0.89, and we excluded of the analysis patient with severe left or right ventricular dysfunction, cardiogenic shock, and the non-consecution of an optimal result of the culprit vessel during the index procedure. Patients were 66-year-old and 77% were male. 307% had a personal history of diabetes, and the clinical presentation was no STEMI in 66% of the patients and STEMI in 34%. The mean left ventricular ejection fraction was 55%, and the radial axis was the choice axis in more than 90% of the patients, who presented a mean syntax score of 15. The most frequent culprit vessel was the right coronary artery, followed by the LAD artery, that was the most frequent non-culprit vessel analyzed. The primary endpoint of the study was the incidence of MACE at follow-up, and as secondary endpoint, we established the following. First, to analyze the components of the primary endpoint separately. Two, to explore predictive factors for MACE. Three, to calculate the risk of MACE depending on the clinical scenario, STEMI versus no STEMI. And four, to calculate the risk of MACE according to the IFR obtained during the procedure. I mean, patients in whom at least one deletion presenting an IFR higher than 0.89 and patients in whom all deletion analyzed presenting an IFR lower than 0.89 who were revascularized. Yes, we observed a total incidence of MACE of 9%. Patients with this strategy presented at 22 months follow-up an incidence of cardiac death of 1.4%, an incidence of myocardial infarction of 3.4%, an stent thrombosis of 0.3%, and a need for repeat vascularization of 3.9%. Regarding secondary endpoints, we observed that there were no differences in terms of MACE between patients who presented with STEMI and no STEMI. And finally, for me, the most important finding of the study, we observed that patients with at least a non-corporate lesion with a baseline IFR higher than 0.89 Therefore, for PCI, a total of 251 patients presented a similar incidence of MACE regarding patients in whom all the lesions analyzed presenting an IFR lower than 0.89 underwent complete revascularization, a total of 105 patients. We observed that the early predictor of a higher incidence of MACE at follow-up was the presence of a personal history of prior coronary revascularization, but not, for example, the presence of non-culprit lesion without physiological significance deferred for PCI or the type of non-culprit vessel deferred for revascularization. An important point is that although the main type of lesion analyzed was angiographically moderate lesions, the 42% of the lesion can be considered as a complex lesion, diffuse disease, sequential lesions, bifurcation lesion, in-stent restenosis, coronary bypass graft lesion, etc. Yeah, I think that the main conclusions are first, that an IFR guided PCI strategy in non-culprit vessel in patients with acute coronary syndrome seems to be safe, with an acceptable percentage of MACE at the midterm follow-up. And second, that patients with PCI deferral of lesion without physiological significance and patients undergoing complete revascularization show with a similar rate of cardiac adverse events at follow-up. Yeah, I think that the take-home message is that it's feasible to guide PCI decision-making with the use of IFR in patients who present an acute coronary syndrome, STEMI and non-STEMI, with successful revascularization and other non-culprit lesions. Using the same cutoff value that they established in the main trials, we know that the probability of suffer a MACE during the follow-up is similar in patients in whom at least one of the lesions evaluated presents an IFR higher than 0.89 and those patients with complete revascularization. Yeah, I think that this study can be considered as an hypothesis generator. I think that it's necessary a specific randomized clinical trial to confirm this result. But until we have a specific study, I think that these results are very useful for the interventional cardiology who have to take decision making in this clinical scenario and daily.